Good afternoon, everyone, and welcome again to Center for Vein Restoration's National CME Series. We appreciate you joining us this afternoon. At this time, I would like to introduce Dr. Ken Nguyen, who will provide more information about today's CME and our CME presenter.
Hello, everyone. Welcome again. As Jessica said, I'm the Chief Medical Officer for Center for Vein Restoration. It's my honor to have you guys here today. I'm covering for Dr. Lockenpaul. He's got a prior engagement, but he'll be back for the next talk. At the last talk we had over 400 participants and attendees, and we really want to thank you for participating, and I hope that you're getting as much out of these as I am. I'm going to go ahead and share my screen. Are you guys able to see that? Just a reminder, please mute yourself upon joining the presentation. And please submit your questions through us through the Zoom chat. You'll be receiving the CME certificates through the CVR physician, through your physician liaisons, and you'll be able to access the CME presentations through the websites listed. If you have any questions or suggestions, you're also more than welcome to reach out to me as well. Just a little bit about Center for Vein Restoration. We currently have over 90 clinics in 16 states. We have 500 full-time physicians with 62 active physicians as well. 40,000 new patients seen in 2019. And last year we saw almost 200,000 patient interactions. Our goal is, and the purpose of our practice is really to not only be a service to our patients and to our community, but also to advance the field. And that's the reason why we're doing these talks. This slide is the reason why this is our strength. It's our physician and clinical teams who dictate clinical care through a phenomenal operational, financial, as well as administrative marketing and support. This is why we're able to do the things that we're able to do, just because of all of the folks on this photo. So our topic today is going to be pelvic congestion, and it's my honor to introduce my friend, Dr. Peter Pappas. He obtained his medical degree from Robert Wood Johnson Medical School, completed a general surgery residency at Cooper Hospital University Medical Center, and then went on to a vascular surgery fellowship at Rutgers, New Jersey Medical School. He's the former professor of vascular surgery and chief of vascular surgery at New Jersey Medical School, former chair of the Department of Surgery at Brooklyn Hospital Center, and professor of surgery at Rutgers. He's also the past president of the Vascular Society of New Jersey, as well as the American Venous Forum and the American Venous Forum Foundation. Currently, he is the regional medical director for the New Jersey North region, and he's also the program director for our fellowship program as well. Without any further ado, Peter, it's all up to you. Thank you very much.
All right, thank you, Ken, for that very nice introduction. So if you can unshare your screen, I'll share mine. Thank you. Yeah. Share. There you go. So today's topic is on pelvic congestion syndrome. So one of the first things I would like to tell you is that this is a very old name for a very common problem. It was originally coined in the 1940s. So there is a large effort going on amongst many of our societies today to rename this entity to pelvic venous disorders, which is a better term which describes all the multiple different causes of pelvic problems in primarily women, but we also see them in men. So to emphasize that fact is this is a differential diagnosis of all the potential causes of pelvic disorders, and it's by no means an extensive one. But as you can see here, there's the usual gynecologic issues, but we also have urologic issues, neurologic issues, gastroenterologic, hematology, oncology, musculoskeletal. So, but today we're going to focus on issues specifically related to one area of pelvic venous disorders, and that's pelvic venous insufficiency. So part of the problem with the term pelvic congestion syndrome is the definition. So the classical definition is that in order to label somebody as having pelvic congestion is that they have to have chronic non-cyclical pelvic pain for greater than 6 months. The problem with that is that many women in particular present with a vast array of different symptoms that may or may not be associated with chronic pelvic pain, but are still secondary to a pelvic venous disorder. So it's been estimated that 2 to 10% of all gynecologic consultations are for some form of pelvic pain. 20% of the laparoscopies that are performed today, primarily looking for endometriosis or other causes of pelvic pain, are due to pelvic congestion or pelvic venous disorders. And of all of the causes of a pelvic venous disorder, up to 40% of them are due to pelvic venous insufficiency, which is a dysfunction in the veins of the pelvis. So, what are some of the signs and symptoms that women will present with when they have a pelvic venous disorder? So typically we see this in women who have had 2 or more pregnancies, pelvic bloating not associated with menses, dyspareunia, which is defined as pain with vaginal intercourse and in particular deep vaginal penetration, postcoital pain that can last from minutes to hours after intercourse, avoidance of intimacy with the spouse due to the fear of generating these pain symptoms, urinary frequency, particularly at night. So we often have women complain about getting up in the middle of the night every 2 hours to urinate up to 3 or 4 times a night. Mid-epigastric pain, which is often confused with peptic ulcer disease, but can be due to an entity called nutcracker syndrome, which is a stenosis of the left renal vein. And then we have some of the signs which are very specific for pelvic venous disorder. So specifically vulvar varices, either during pregnancy or that continue after pregnancies, is usually indicative of a pelvic obstruction. A suprapubic varicosity, which is a bulgy varicose vein that goes across your pubis, is often a collateral vessel that is due to a iliac obstruction. High medial thigh varicosities, again, you have a obstruction or a stenosis, and these are called escape veins. Veins that emanate from the gluteal fold or down the lateral thigh are also escape veins, and I'll show you some example of those in a moment. And vaginal edema or varices that you see in the vagina on a speculum exam is also consistent with a pelvic venous disorder. So let's review the anatomy a little bit so you get a better understanding of what the causes are. So the first thing you need to know is that the veins that are affected are your common iliacs, external, internal iliacs, and the ovarian veins in particular. But keep in mind that what you see on the surface when you're doing a physical exam is just the tip of the iceberg, because there are major other variabilities that can go along with these anatomic abnormalities. So quickly, this is what the inferior vena cava looks like. This is the aorta, and you can see here that that's the left common iliac vein, and the right common iliac artery sits on top of the left common iliac vein. This is the most common location where we see an iliac stenosis, oftentimes referred to as the May-Thurner syndrome. This is the ureter, and this is the left ovarian vein. So this is an example of what a dilated ovarian vein looks like. So this is your uterus, ovary, and this is a very dilated, large ovarian vein. Now, the ovarian vein anatomy typically is like this. So 2 to 4 trunks come together right at the pelvic brim to form the one ovarian vein. On the right, the ovarian vein attaches to the inferior vena cava 90% of the time, and in 10% of the time, the right renal vein. And on the left, it's almost uniformly found emanating from the left renal vein. The average diameter is between 3 and 5.5 millimeters, and this is important. I'll tell you in a moment why. And typically you see about 2 to 3 valves in the ovarian vein. One of the most important things is that ovarian vein reflux is seen in up to 40% of women, and they are asymptomatic from it. So clearly you need to have more than just a little reflux in order to have pain. And we'll go over what some of those criteria are. So this is a diagram of what we just talked about. So over here on the left, you see the left ovarian vein. Multiple trunks come together to form it. They surround the ovary, and then there are connections through the pampiniform plexus that connect to the uterine vein, which comes off the internal iliac vein. And these cross-pelvic collaterals that you see here, these arcuate veins that go over the uterus, are very, very common. So for example, this is a venogram indicating all of those things. So here's the ovarian vein, here's the ovary with the pampiniform plexus, connection to the uterine vein, these arcuate veins over the uterus, also connecting to the right side, and then this is the right ovarian vein in this patient. So let's, what do you see on physical exam? So you don't see this very well, but in this picture, there is actually a vein that's emanating from the gluteal fold here, and then it wraps around to the side here, down the lateral thigh. This is a typical example of an escape vein from an inferior gluteal vein, typically because there is an obstruction proximal to it. This is a vulvar varicosity. This is a woman who's had 2 pregnancies. Her last one was a twin birth, and her vulvar varicosity never went away after her delivery. This is an example of a suprapubic varicosity. You can see these little varicosities here going across the pubis. This patient had an external iliac occlusion from a deep vein thrombosis in the past. These are high thigh varicosities. Now you can see there's multiple varicosities here. This is not coming from the great saphenous vein. This is from the internal pudendal vein, and it's also an indication of an escape vein, also indicative of a proximal occlusion. So all of these signs are usually have a 90 to 95% sensitivity that there's a proximal pelvic problem. So what is the diagnostic evaluation? So the first thing is that, well, let me back up a second. All of the patients who come to the Center for Vascular Medicine for an evaluation, we always make sure that they've had a gynecologic evaluation first. And all of our gynecologic colleagues are very good at doing transvaginal ultrasounds. But one of the things I would like you to take away, if you are one of our gynecology colleagues, is please ask your technologist to turn on the color box. And the reason for that is if you see pelvic varicosities on the color box in a transvaginal ultrasound, that is 95% sensitive that you have pelvic venous insufficiency. Also, it's not uncommon for our patients to come in having had a laparoscopy, and during laparoscopy, photographs are taken, and then the patients often show us the varicosities in the pelvis that you can see during laparoscopy. Now, fortunately or unfortunately, a gastroenterologic evaluation is often done because these women have the abdominal pain, and they oftentimes get sent to the gastroenterologist, and they usually get an upper and lower endoscopy, and they may or may not get a CT scan of the abdomen and pelvis. So, and then the next is they really should see a pelvic vein specialist. If they have had a CT scan or an MRI done, I always ask that they bring the study in because the report oftentimes misses the enlarged ovarian vein and the pelvic varicosities. So I would encourage you not to rely on the report, but to actually look at the study. And also we can make the diagnosis on a duplex scan, and I'll show you some pictures of those in a moment. A lower extremity reflux scan is often done because in one of our previous publications, we found that over 60% of women actually present with lower extremity varicosities, and after they get their varicosities treated, their pelvic source becomes manifest. And then we perform a pelvic ultrasound, not looking at the solid structures. We look mostly at the venous structures to see if there is a stenosis, if there is ovarian vein dilatation with reflux, or any evidence that there might be an obstructive component. So this is an example of a transvaginal ultrasound that a patient of mine came with here. And you can see here, this is a very nice B mode. And the gynecologist was able to put the color box on, and you see all of these pelvic varicosities here that light up. This is, like I said, 95% sensitive that there is a pelvic venous insufficiency source. So again, here's that same pelvic ultrasound now with the MRI. And you can see here all of these white vessels here. These are varicosities that are surrounding the uterus and sitting on top of the bladder. So another MRI and a sagittal view, and this one you can see here, the dilated ovarian vein, connections down to the ovary through the pampiniform plexus. Again, these arcuate ligaments. And also, if you look very carefully here, you'll see that there's a stenosis here right at the common iliac as well as in the inferior vena cava. In this one, this is a CT scan without contrast. Again, the sagittal image. This CT scan was originally read as being normal, but you can see here there's a very large ovarian vein that leads into this large source of these pelvic varicosities. So when these patients are seen at our institution at the Center for Vascular Medicine, this is what we look for on a transabdominal ultrasound. We focus in on the external iliac artery, and then we find the psoas muscle, and right above it is where the ovarian vein is. And here you can see this is a very dilated ovarian vein in the supine position. It measures 0.56 centimeters or 5 millimeters. And here, this is 0.8 millimeters. This is a very, very large ovarian vein. And then we can put the cursor on, we can do a spectral waveform analysis, and we can see here that there is reflux in this ovarian vein. So this is a very nice study that was published, which looked at the incidence of ovarian vein diameter and the incidence of pelvic congestion syndrome. And as you can see here, that when the vein gets to be larger than 5 millimeters, especially 6 millimeters or larger, there's almost a 90% correlation that there is some ovarian vein or pelvic venous insufficiency in these patients. So that's why we look at when we see a 0.5 or larger, we look for reflux. And again, remember, most of these ultrasounds are done in the supine position. If they're in reverse Trendelenburg, they should be dilated even further, or if you have them do a Valsalva maneuver. So once you make the diagnosis, how can you treat it? So let's do a quick case presentation of a 52-year-old Hispanic female. She's had a previous right grade saphenous vein stripping, right inguinal hernia repair, tubal ligation, diverticulosis, and an ascending colon ulcer, who presented to a GI doctor complaining of 10 to 20 episodes of mid-epigastric pain a day, requiring large amounts of Tylenol for her pain. She had an upper endoscopy, which was negative, a HIDA scan, which was positive for acalculous cholecystitis, and during a laparoscopy for her pelvic pain, she was found to have a large fibroid uterus with ovarian cysts. No evidence of endometriosis. She had a cholecystectomy done for the acalculous cholecystitis with no resolution of her pain. And then finally, a CT scan of the abdomen and pelvis was ordered by the gastroenterologist. And on further questioning her, her periumbilical pain started at her umbilicus, migrated to her mid-epigastrium. And she also, her daughter said that she could actually see her pelvis actually expanding when she had her pelvic pain. So on physical exam, she was depressed, tearful, and anxious. No caput medusa or abdominal masses, no vulvar or gluteal varices, and no lower extremity varicosities were seen. And she had a UA, which was negative for blood. But this was their CAT scan. This is the previous CAT scan I showed you before, which was originally read as being normal. Dilated ovarian vein, large pelvic varicoses. But in addition, when you look at the cross-sectional images, you can see here that this is the superior mesenteric artery. This is the left renal vein where the diameter is less than 3 millimeters. And there was some pre-stenotic dilatation of 9 millimeters. These two criteria of a renal vein less than 3 millimeters at the superior mesenteric artery with a pre-stenotic dilatation of greater than 9 is consistent with a syndrome called Nutcracker syndrome. Nutcracker syndrome can mimic mid-epigastric pain. So here what we did was we embolized the left ovarian vein with some coils and with some foam. And then we also went ahead and we measured the right renal vein where the compression was. And we went ahead and we placed a stent across the compression. And here, this is what the stent looks like on CT scan. And you can see here evidence of the coils. A week after this was done, the patient stopped using Tylenol. She was no longer tearful or depressed or in pain. And her family said that she was a completely different person once her pain was resolved. So this is a venogram showing you what ovarian vein reflux looks like on venography. So you can see here the catheter is in the left renal vein and the left ovarian vein is massively dilated. So we put the catheter down at the pelvic brim where the branches are. And you can see here that the dye goes into the ovarian pampiniform plexus. Again, you see evidence of this cross-pelvic collateralization, and it fills the right ovarian vein on the right side in this patient. Here's another venogram showing a right common iliac vein stenosis right here. You can see it looks like an hourglass. And then over here, a very severe left common iliac vein stenosis. And these venograms are both in the same patient. So here on the left, you can see the stents that were placed. And then on the completion venogram, you see there's no obstruction to flow anymore and the lesions are gone. So it's great that we have all of these tools at our hand, but what are some of the long-term results here? So we recently published a paper in 2018 looking at our results in 224 women. And what we did was we divided these women into the causes of their pelvic venous insufficiency. So specifically, if it was ovarian vein reflux alone, women who had an iliac stenosis and reflux, women who had a stenosis alone, and then the various treatment regimens. So the average age of the women in this study was 46. The average number of pregnancies was 3.3. And as you can see here, they actually had other gynecologic reasons as well. So there was 17 who had endometriosis, a previous hysterectomy, and fibroids. So it's not uncommon to see both of these entities along with women who have pelvic venous insufficiency. So then when you look at the distribution, you see it's a typical bell curve distribution with the majority of the patients being older than 40, but you can see it still happens in younger patients as well. Again, average number of pregnancies is 3 or more, some of them that were 2, and we even had some that were 1. Then when we looked at the results in terms of visual analog pain scores, what we see is that the women who had ovarian vein reflux alone, although their pain score was high at 7.4, it wasn't as high as the women who had an iliac stenosis as well, who were in the 8s close to the 9. In addition, after they were treated with their stenting or their embolizations, the women who had ovarian vein embolization alone went down only to a 3. And this is pretty consistent across papers that you see in the literature. But the women who had the stenting went down to 1, and many of them had complete dissolution of their pain altogether. Now, the majority of the women that we see in our practice, about 50 to 60% of them, have a combination of ovarian vein reflux and iliac stenting. So we wanted to know, well, which one of these is the primary lesion? So we had a group of women, 90 women, who we embolized first and then stented them. And that's the group here in the red here who were embolized first. And what this shows was that only 9 out of the 90 reported any improvement with the embolization alone. It wasn't until they were stented that their symptoms improved dramatically. And then we had another group that we did the embolization and stenting simultaneously. And again, dramatic improvement, but not to the same degree as the group that was staged, suggesting that there is a subgroup of women in which the ovarian vein reflux is important to treat. So we're trying to figure out which group that is. And we have another paper that we're going to present at the American Vein and Lymphatic Society looking at this specific issue. So we then, my colleague, Levan Silkevich, just did another presentation at the AVLS last year, and his paper has recently been accepted to the Journal of Phlebology, also looking at how women present based upon their age. Again, same kind of distribution, most of the women being in 40 or older. And one of the things that he found was that as women get older, their incidence of leg symptoms increases and their incidence of pelvic symptoms decreases. So pelvic symptoms usually are seen in women who are younger in the 30s and 40s. But as they get older, the pelvic symptoms diminish, which is consistent with them going into menopause. But their leg symptoms increase. So another thing that we looked at is how were they treated? Again, not much different than our 2018 publication. About 50% of them had combined embolization and stenting. Another 40% had stenting alone, and a very, very small subgroup of women, as you can see here, only about 7% of them had ovarian vein embolization alone. Then when you look at the types of treatments, again, pretty much the same as the previous paper in 2018, but this is the take-home message here. This blue line at the very top here are women who are in their 20s. Women in their 20s, when they get treated, you see an improvement at 1 month, but then by 3 months, their symptoms all go back almost to baseline, and they pretty much stay there. So the take-home message from this paper is that women in their 20s probably should not be treated with embolization and stenting first. They should have a really extensive, thorough gynecologic evaluation to look for other causes of their pain. And there is some protective effect to pregnancies, which then alters the pathophysiology somewhat. So what about lower extremity reflux patterns? So this is another paper that we presented a couple of years ago, again at the AVLS. And what we did was, of those 224 women who we had diagnosed with pelvic venous insufficiency, we said, what percentage of those women actually had lower extremity varicosities? And what we found was that 55% of these women presented with lower extremity venous disease. Only 10% of these women presented with what we call the traditional escape veins. Remember those pictures I showed you of the veins coming out of the gluteal fold, down the lateral thigh, the vulvar varicosities, the high medial thigh? We only see that in about 10% of patients. The vast majority of these women actually have the typical run-of-the-mill great saphenous vein reflux. Also, to our surprise, we thought that the women who had the pelvic venous stenoses would have the higher incidence of varicosities, but what we see is it's actually highest in the women with ovarian vein reflux. And what that suggests is that the hormonal changes that you see with pregnancy are actually probably related to some of the development of lower extremity varicosities. And we also know that varicose veins are genetic. So it's an autosomal dominant, it gets passed down to every generation, but it requires environmental factors to activate it. So in women, it tends to be hormonal. So again, in our women who had documented pelvic congestion syndrome, only 10% of them showed escape veins. The vast majority had lower extremity veins. So it's not uncommon for us to treat these varicosities, and the women may still have some residual symptoms, at which point we then look higher into the pelvis. So, conclusions. Pelvic congestion syndrome is an old term. We now call it pelvic venous disorders. And of those pelvic venous disorders, about 40% of that is caused by pelvic venous insufficiency. A good history and physical exam are the keys to identifying these patients, because as I showed you earlier in that differential diagnosis, there are many, many things that can cause pelvic pain, which are musculoskeletal, neurologic, hematologic, gastroenterologic, gynecologic. But the history and the physical really will help you identify many of these women with pelvic venous insufficiency. A transvaginal or transabdominal ultrasound with or without CT scanning is a good screen, especially if on transvaginal ultrasonography, you put the color box on and you see these periuterine varicosities. That's almost 95% sensitive for identifying some of these women who have pelvic venous insufficiency. And then finally, the treatment. We've really come a long way in our understanding of how to treat these pelvic venous disorders that are related to venous insufficiency. A thorough diagnostic venogram, which will include looking at the internal iliacs, the external iliacs, and when necessary, looking at the ovarian veins. We firmly believe that our data indicates that stenting of these lesions is the best way to treat them, because the majority of these women tend to have complete dissolution of their symptoms. We do use ovarian vein embolization, and I had alluded to the fact that we had recently submitted an abstract to this year's AVLS. And I'll just let you know that what we did was we looked at about 38 women who had ovarian vein reflux and an iliac vein stenosis. And of those 38 women, all we did was stent them. 80% of those women had complete dissolution of their symptoms. 4 of the women who had a partial response, and of those 4, they had a pelvic reservoir. But of the women who got stenting, half of them also had a pelvic reservoir. So there is a subgroup in there, and we believe it's not just ovarian vein reflux, but there has to be a large pelvic reservoir. And in that subgroup of women who have an iliac vein stenosis with a large pelvic reservoir, they're the ones who probably should have either staged or simultaneous treatment. Then finally, we hit many, many women who have a vulvar varicosity. And in that group of women, you have the option of actually, under ultrasound guidance, placing a needle in the vein in your office and treating them with foam, rather than taking them to the operating room and doing venography with possible embolization. Also, in our women who present with lower extremity varicosities, we always recommend that the varicosities be treated first, because there's some suggestion that in some women who have iliac stenoses, 30% of them are asymptomatic. So we like to do the lower extremity things first, because it doesn't involve putting in a stent or a permanent implant. If we can do something simple like an ablation or a phlebectomy or an injection procedure and avoid the implant, that's always our preference first. But then if they're still having residual symptoms of leg pain or swelling or pelvic issues, then we move on to the abdominal ultrasound with the venography and or stenting. Also, remember, great saphenous vein reflux is the most common varicosities that we see. Only 10% of women have the classic pelvic escape veins, of the high thigh, the vulvar varicosities, the gluteal fold, or the lateral thigh vein. And pelvic venous insufficiency is the most common cause of some of these pelvic venous disorders that we see, especially in women who are greater than 40 years old. And then finally, if you see women in their 20s who are complaining of pelvic pain, our results indicate that treating their pelvic venous insufficiency may have an initial short-term response, but it is not a good long-term response. By 3 to 6 months, most of these 20-year-olds have a recurrence of their symptoms, and we strongly suggest that they be evaluated for other causes of their pelvic venous insufficiency. So at this point, I'm going to end. I'd just like to also remind you that our next national CME program is on Tuesday, September 22nd at 6:30. It's going to be by my colleague, Dr. Mehul Shah, and it's going to be entitled Tips and Tricks to Dealing with these telangiectasias. So thank you very much for your attention. And at this point, I'm going to stop sharing and answer any questions that may have come through. So let me do that. All right. So hold on, Ken, I'm trying to get back on. All right, Ken, you're muted.
You need to unmute me. Okay, great. Hey, Peter, thank you very much for a phenomenal talk. I can tell you that now I know why our fellows are always raving about how great of a director you are, and we are very fortunate from CVR to have you as a leader in our research and as our fellowship director, as well as a mentor to all of us. So thank you very much for that concise presentation on pelvic congestion.
My pleasure.
The first question we have is from Dr. Stephen Doherty from Tennessee. Stephen, thank you very much for being on today. His question, Peter, is when do you choose endovaginal duplex ultrasound? When do you choose to use endovaginal duplex ultrasound?
So our protocol is that before we consider doing any of these pelvic venous insufficiency disorders, is that they all be evaluated by a gynecologist first, because as I said, there's a very extensive differential diagnosis, and we don't want to be treating an iliac vein when there may be some endometriosis, some ovarian cysts. So for the most part, almost all of our women come in with a transvaginal ultrasound. What we notice though, is that the majority of the techs who are trained in transvaginal ultrasonography do not use the color duplex box. So when we're out talking to some of our gynecology colleagues regarding this, we always encourage them just to turn the box on to see it, because if they do see varicosities or they do see color surrounding the uterus, like I said, that's 95% sensitive. So almost all of our patients, Steve, come in with a gynecologic evaluation already from our colleagues.
Thanks, Peter.
Just to be clear that we don't have a transvaginal ultrasound at CVM. We just do transabdominal ultrasonography.
Thank you. The next question is from Dr. Chuck Mesh from Illinois. Thanks, Chuck, for joining us today. His question is, can you define what is meant by the term pelvic reservoir and talk about its significance?
So that's a really good question. So as I alluded to the talk, that there's a multidisciplinary intersocietal group that was started by the American Vein and Lymphatic Society, the American Venous Forum, the Society for Interventional Radiology, I think the SVU and the Society for Vascular Medicine are some of the groups that are involved in this. And so one of the things that they're doing, which I didn't mention in this talk, is they're coming up with a classification system similar to the CEAP system. So one of the things that they had asked Dr. Labropoulos, who is chairing the ultrasound committee, was to come up with some definitions. And one of the definitions was specifically related to a pelvic reservoir. So currently what the definition is the identification of 3 separate segments, either ipsilateral or bilateral, of varicoses within the pelvis. If you can identify 3 separate segments, either by ultrasonography, CT scan, or MRI, that's considered a pelvic reservoir.
Thank you. Dr. Arawani his question, Peter, is do vulvar varicosities need sclerotherapy during ovarian vein embolization, or will they resolve on their own post-embolization?
So that's a really great question. It all depends on how thorough your venography is. So one of the recommendations, especially Mark Miser is a very big believer on this, is that you have to do internal iliac vein venography to try to look for some of these sources, and specifically balloon occlusion venography. So what he does is he takes basically a thrombectomy catheter that has a balloon on the end of it. He puts it in the internal iliacs and he shoots a venogram, tries to identify the segment where there's an escape vein or these valvular varicosities, and then put a catheter down into that one segment and then embolize it. So that's one way of doing it. Another way that's also been described is varicography. So again, you're in the interventional radiology suite. You have a needle in the vulvar varix. You shoot some dye into it to kind of see where the dye travels to, and then you inject some dye. I will tell you, my experience with relieving the obstruction and having the vulvar varicosity go away just with venography has been poor. I usually end up doing another procedure, usually in the office, where I stick a needle into the vulvar varix and inject some foam. And I've had a lot of success with that. Kathy Gibson over at the university, over in Seattle, also does a lot of these vulvar varicosities in the office, also with a lot of success.
Great. Dr. Pratt, his question is, though not statistically significant, how do you explain the decrease in pain across the venoplasty alone? Decrease in pain scores across the venoplasty alone.
Yeah, so I don't really believe that venoplasty works. I think that study that I showed you only had a 3-month follow-up in that 2018 publication. We've subsequently repeated this study looking up to 2 years. So we don't routinely do venoplasties. We only do this in patients who really don't want the stent, but want something done. And in those patients, I will tell you, they come back for serial venoplasties. So I wouldn't hang my hat on the venoplasties, because remember, the lesion in a vein is caused by external scar tissue, fibrosis. It's not an internal occlusive lesion like an artery. So what happens is when you do a venoplasty, you're going to get some recoil, and inevitably your symptoms are going to come back. So you're only going to get a temporary reprieve from that. But again, it's something that we offer patients who really, really don't want the stent done. But in my experience, it doesn't work well at all.
Great. Boy, these are really good questions. And I'm glad I'm not answering the next one, but this one is from Dr. Daniel Folk from Argentina. And his question is, which classification is more accurate for you, the American or the Latin Iberian?
So which, you mean for pelvic venous disorders?
That's correct.
So right now there is no classification system in the United States. I will tell you though, that multi-specialty group that's working on it right now, they've developed a system called the SVP system. So S stands for symptoms, V stands for the anatomic location, and P stands for pathophysiology. And I actually debated showing that to you, but so let me tell you how it goes. So the S has 4 subgroups, S1, 2, 3, and 4. And so if you have nutcracker syndrome or an iliac lesion, that's an S1. If you have pelvic venous insufficiency from the renals down to your pubis, that's an S2. If you have escape veins that are pelvic in origin, that's an S3. And if you have lower extremity varicosities, that's an S4. So theoretically, you can have a pelvic iliac lesion and say varicosities, you would be an S1-4. And then on the vein side, it's the same thing. It's a V1 would be renals, V2 would be abdominal iliac sources, and then V3 and V4. And then on the pathophysiology side, you can actually have it's either primary or secondary. But going back to the V for a second, there's also anatomic subgroups. So if you know that you have left ovarian vein with the left iliac, you would be a V2 LOV LCIV. So it's a very, very complicated system, but it was meant to mimic the CEAP classification system created by the American Venous Forum. It's also meant to be descriptive. It's not meant to be quantitative. So why is that important? Because just like in CEAP, you have a revised venous clinical severity scoring. There is no correlate and for pelvic congestion syndrome. So it's very difficult to quantify how much disease you have and whether or not you have a response. Whereas with the VCSS, we know that if you're a 20 and you go down to 3, you had a good response, but we have no correlate, which is why, visual analog pain scores are the only thing we have. And it's not very good because there are multiple other causes for pain in people. So right now, we're still in the infancy. I think the SVP classification, if I'm not mistaken, I think they're about 3 months away. I think the writing group is actually in the process of writing the manuscript, and they anticipate about 3 or 4 months before that comes out in the literature. And then right now, if you want to make some research headway, develop a correlate to the RVCSS for pelvic pain.
Fantastic. I have a question myself, Peter. When you are treating patients with both pelvic and leg symptoms, I know that you had said that if you're going to do the least invasive procedure, go ahead and treat the legs first. But are there any instances where you would treat the pelvis first?
So probably not. And the reason for that is that, remember, what I tell the patients all the time is that pelvic venous insufficiency is not like having peripheral arterial disease. If you have an occlusion in your artery, you can, have a heart attack, you could have limb loss, you could have a stroke. But pelvic venous disorders are always quality of life issues. So, and the other thing that bothers me the most about it is, though, our patency rates for the stents have gotten much, much better. I tell the ladies that they have about a 10 to 15 year stent patency for the non-thrombotic lesions. It's still not 100% for life. So I really don't want to put in, especially for a 20-year-old or a 30-year-old, I really hesitate to put a stent in somebody and then and without being able to tell them at 20 years that it may not stay patent. So I always tend for the lesser invasive options first, and then move my treatment algorithm is then move up to the more invasive things later. So I guess the only instance where I could think of maybe doing the stent first is if their primary symptoms is just pelvic pain. They've got varicosities that are asymptomatic. That's not what's bothering them, but it's the dyspareunia, it's the avoidance of intimacy, it's the effect it's having on their personal relationship. That might be the only indication where I might consider doing the stent first.
Thank you, that's helpful. Dr. Kennedy from Miami, his question is, if there's one classic symptom that you would look for in these patients that tells you, this is pelvic congestion, is there one symptom that will point you to the diagnosis?
Yeah, there's very, very few things that can cause dyspareunia and postcoital pain. There's nothing else that I'm aware of the differential diagnosis that can do that. So when I have women, tell me, and it's, by the way, it's not uncommon for many of these women to come in with their spouses, because this is a very difficult conversation, and you have to explain to the patients why you're asking them this, because it seems like it's coming out of the blue. But dyspareunia and postcoital pain, almost 99% of the time, it's due to an iliac or an ovarian vein reason, because I'm not aware of anything else that can cause that kind of symptomatology.
Got time for just a couple more. Next one is kind of interesting. Do any of these procedures, embolization or stenting, impact childbearing? So
that's another good question. So we have another abstract that we just submitted. We have 14 patients who have subsequently gotten pregnant after their stenting. So ovarian vein embolization does not affect fertility, and the gravid uterus does not affect stent patency. So these stents, especially the newer stents, have a large radial force to them. They're very resistant to compression or being crushed. So we say with pretty much confidence that it doesn't affect your fertility, and in addition, go ahead and get pregnant afterwards. All we ask is that after your pregnancy, you come back so that we can just do a quick ultrasound. The one thing that is a little controversial in my mind is currently the recommendation from a lot of our gynecologic colleagues is that during the pregnancy, they be placed on low molecular weight heparin or Lovenox, just to kind of prophylax against any potential stent issues. But there's no data to support that. It's just kind of a best practice kind of thing right now.
Thank Dr. Landau, Michael Landau, his question is, if you find a patient with a need for iliac and ovarian vein insufficiency, who would you recommend that patient be referred to for definitive treatment such as embolization, stenting? A vascular surgeon, interventional radiologist, he does not offer these options, but he is trained in them. He's asking for what would you recommend?
So I really don't care what your subspecialty is. I care more about the fact that you have an interest in doing this. So, you know, interventional radiologists are more than capable of doing it, but a lot of them were trained in only to do ovarian vein embolization. So I think it's more important that you get sent to a pelvic vein specialist rather than a vascular surgeon, an interventional radiologist, or whomever. So, and what that means is you got to do some homework on your part. You have to find out who in your area is interested in doing that, or you could just contact the AVLS, or you can contact us at CVM. We pretty much know everybody in the areas that kind of are experts at doing this.
Thank you. So we will take one more question, and let me choose a good one here. This is a good one, I think. So Peter, do men get pelvic congestion syndrome, and what are the symptoms that they typically present with if they do?
So that's a really good question because I get asked this all the time. So men typically present with lower extremity pain and swelling from their iliac stenoses. Occasionally, you will see a person who's got scrotal varices. You know that, and in those patients, sometimes it's because they either have a nutcracker syndrome or because they have an iliac lesion. But more often than not, they usually present with severe chronic venous insufficiency, C4AB disease, a venous ulcer, really horrible leg swelling, and very now and then, I think I can count on one hand the number of people I've seen with a varicocele that was probably secondary to an iliac lesion.
Oh, thank you very much. Again, just a phenomenal presentation, Peter. And thank you guys, everybody, for tuning in. And we look forward to having you guys again on September 22nd, when our very own Dr. Mehul Shah will be presenting some tips and tricks on treating spider veins and telangiectasias. Until then, take care.
All right, thank you very much, everyone. Appreciate your time today.
Thank you all again for attending. Please make sure that you check the survey links in the Zoom chat feature. You'll also be receiving an email with further information, but please make sure that you take the survey that is linked in the chat, as well as you'll see the registration link in the chat for the next presentation. Thank you again for attending this afternoon. We appreciate your time.